So the vasoconstriction makes the blood pressure go up, and the carotid bodies sitting right here go, whoa, the blood pressure is good. And it's not heart rate that delivers oxygen to the tissues, it's blood pressure. It's really cardiac output, but we don't measure that, so we're going blood pressure. So the carotid bodies go, whoa, pressure's good. Heart, here, I'm going to send a signal down the vagus nerve to slow you down. You don't need to work so hard. The pressure's fine. It's brilliant.
Hey, VetFolio Voice listeners, welcome back. We've got a great episode for you. Dr. Tammy Grubb is joining me once again. I love talking all things anesthesia with Dr. Grubb. We were actually talking about it before we turned the microphones on, and I told Dr. Grubb that she's somebody that I love talking to about this stuff because the way that she explains it, she's got this way of making the information feel really accessible. The way she talks about it, it just makes sense, at least it does in my brain, and that was certainly the case for this topic as well. This talk went a long way for me in addressing this internal conflict I feel sometimes when I'm anesthetizing older patients. If you've listened to the podcast, you know I enjoy doing dental procedures, and when you're handling those kinds of cases, oftentimes we're dealing with older patients with comorbidities, and there can be this little bit of trepidation around anesthesia in those patients. And in the past, that has created sort of this disconnect for me because in my head I'm going, well, age is not a disease, but my gut is still telling me that I should tread carefully and be a little bit more cautious with anesthesia in these patients. And Dr. Grubb helped explain that trepidation I know I've experienced. I'm assuming I'm probably not the only one. In this conversation, she helps explain that true, age is not a disease. We can't pick an arbitrary number and say any animal older than 7, let's say, is at a higher risk of anesthesia because they're 7. And that's because every animal ages at a different rate. So that number is not necessarily a good indicator of anesthetic risk. When Dr. Grubb explained the concept of frailty, though, it helped me make sense of that gut check I feel with certain patients telling me, maybe I need to watch them a little extra closely or, titrate my drugs a little bit differently when I'm putting them under anesthesia. She explains that frailty is not about age. It has to do with the amount of physiologic reserve these patients have and their ability to respond to the changes that naturally occur under anesthesia. In an animal that's more frail, that physiologic reserve is reduced, so we need to be prepared to respond to changes like hypotension or hypothermia more quickly than we might in an animal who is otherwise healthy. But that's my version of it. I will let Dr. Grubb explain it. She's the expert. She does a much better job than I do. If you want to learn more about this topic, be sure to check out Dr. Grubb's article, Can a Veterinary Patient Be Too Old for Anesthesia? In Today's Veterinary Practice. It's a great article and kind of inspired this talk. In it, she goes into even more detail about this concept, and there are some great charts with different considerations to keep in mind to just help keep our patients who are more frail safer under anesthesia. Dr. Tamara Grubb is a diplomate of the American College of Veterinary Anesthesia and Analgesia and a certified veterinary pain practitioner. She owns an anesthesia and analgesia and continuing education consulting practice for both small and large animals. Dr. Grubb is a national and international educator and lecturer, a certified acupuncturist, a certified veterinary pain practitioner, an adjunct professor of anesthesia and analgesia, and the past president of the International Veterinary Academy of Pain Management. She is co-author of 2 books, including Veterinary Anesthesia and Pain Management for Nurses and Technicians. Dr. Grubb's favorite achievement is winning the Distinguished Teaching Award from students at 2 universities, and as we listen to her speak here, you will understand exactly why she won those awards. Let's go ahead and get into our episode.
Microbiome science is a swiftly evolving field that has caught the attention of pet owners. Are you prepared to answer their questions? NAVC's brand new veterinary microbiome certification course will give you the skills to implement microbiome science in your daily practice and improve patient care. New research shows maintaining a balanced gut microbiome is vital for optimal nutrition, disease prevention, and longevity in pets. Register today on vetfolio.com.
Well, in this episode, I'm joined by Dr. Tammy Grubb, and I'm so excited to have you back on the podcast. I always love talking to you. This is one of my favorite topics, talking anything anesthesia, and I always learn so much when we get together. So thank you for agreeing to do this.
Thanks for having me back. It is so good to chat with you, and I love all the things that we share, and I hope the audience loves it too. I always learn something from you, and hopefully I educate as well, and it's always so productive. So thanks for having me back.
Oh my goodness, that's so humbling to hear you say you learned stuff from me. I'm like, I don't know what I have to offer in this conversation other than a lot of questions, but that's good to hear. So hopefully, the same thing here. I have no doubt because this is a topic that it's kind of near and dear to my heart as somebody who I really like dentistry, and then I've recently kind of made this transition a little bit away from general practice and into emergency. So we're talking today about anesthetizing older patients and going to kind of change some of the verbiage around there and our mentality for this. But, when you're doing dentistry, a lot of our patients are older and have a lot of comorbidities. And then, similarly, we may be faced with that in the ER, depending on what sort of condition we're looking at.
Yeah, I completely agree. And this one's near and dear to my heart too. So we're going to have a great conversation. And I hope the audience really gets a lot out of this because what we know, because we're in veterinary medicine and what we probably both see a lot from in practices or working with other veterinarians is there's a lot of people that are afraid to anesthetize those senior patients. And I hear that a lot in practices, oh, senior at 7, we can't anesthetize that patient. It's too risky. And not only does that really not ring true, the senior at 7, but also you just hit on the two instances where we have to anesthetize them. They need us. If it's an emergency, we're not going to deny them care because they're aged. And a lot of our patients that have really bad dental disease are the aged patients. And their quality of life is terrible. Those mouths really hurt. They don't want to eat. They do for survival, but they don't want to. It's just not the fair existence for them. So those are two where we can't turn them down for anesthesia.
You said something there that we've talked about a little bit before, and it just blows my mind. Like senior at 7, I'm like, as somebody who loves teeth, like I would be out of a job. I would, what would I do with my time if I couldn't anesthetize anything after 7? Because most of them are like, 12, 13, 14, 15 with comorbidities. And so, I like that you're kind of changing the verbiage around this, changing the mentality. I guess sort of starting at the beginning, where do you think that stigma, that fear of anesthetizing older patients comes from?
I think it's a fair concern because as the patients age, they and we are more likely to develop physiologic changes or pathologic changes, like you've already said, that might put that patient at a higher risk for anesthesia. But for one thing, we've already said we still have to anesthetize many of those. And so I'm hoping for our conversation that people understand what does change with age so that they can respond appropriately under anesthesia and so won't be afraid of the anesthesia. So that's one goal. But then the other goal is to point out that we don't age at the same rate. So something like senior at 7 doesn't really fit because especially look at dogs. I mean, they really age at very different rates. So 7 doesn't mean anything. And so looking at the number of birthdays, that's, I hate to use a cliche, and I love to use a cliche. Age is just a number. It really is just a number. It's a number of birthdays, as I just said. So a certain age doesn't mean anything, but the impact of the birthdays do. So this whole just cut off at an age, it really does. It's not the best way to risk stratify our patients for anesthesia. But back to your original question, I understand the concern that the older patients might have underlying comorbidities. So it kind of became this blanket statement, but we just need to learn to anesthetize those patients, even if they do have the impact of age.
Listening to you explain that, one, I couldn't agree more, but, I was thinking about just this past weekend, an experience I had about dogs aging at different rates. And, if I have an 8-year-old Chihuahua come in and they've got X, Y, and Z going on, it's the differentials are one thing versus I had an 8-year-old Rottie come in with symptoms. And I look at those patients very differently because they do age at different rates and they have different genetic proclivities for things, and yeah, they're predisposed to different things based on their breed, and they age and things, obviously it's individual, but they start to go wrong at different ages. So yeah, really taking time to look at these patients as an individual and say age is nothing but a number and age is not a disease. But there are individual factors to take into account, and making, like you said, making it a fair concern, but learning how to work around those factors so that we can maintain the quality of life for these patients.
I completely agree. And just look at them as if they were any age. We give any patient an ASA status. And I know not every clinic actually really assigns the ASA number, but we have, like you said, a risk factor in our head that we write down in the record. And so we do that across the ages. It could be a young dog that already has, maybe it's a Cavalier, it already has cardiovascular, clinical cardiovascular disease. That's at a higher risk no matter the age. And so you're right, we look at them as individuals and then stratify them that way and then make our anesthesia plan based on the risk factor, not the age itself.
And that's where, I know I've said it a couple of times, kind of changing the verbiage here from your article that you wrote in today's veterinary practice about, can a patient be too old for anesthesia? And you bring up this concept of assessing frailty rather than age, because it kind of takes that across the board looking at a number concept out of the equation and instead allows us to look at these patients more as individuals. So can you talk about the difference between age and frailty when we're looking at anesthetizing patients?
I would love to. One of my
Yay.
favorite topics. Frailty, I wish I had invented it, but it's borrowed from human medicine, human gerontology, where that's a real specialty. And maybe we'll have that someday in veterinary medicine too. But frailty is very different from age. So age, as we've said, it's the number of birthdays. However many birthdays, you could still be perfectly healthy. Frailty is the impact of the number of those birthdays on physiology. Because of course, as we age, as our patients age, we may be more likely to develop organ dysfunction or other pathologies. So again, it's just put it though into a big risk factor, not just the age. So with frailty, what that means is a decrease in what we call physiologic reserve, which is the ability of different physiologic systems to respond to a stressor and overcome that stressor and then be returned to homeostasis. And this really fits under anesthesia, especially because the stressor might be the anesthetic drugs that would cause some hypotension. And in a patient that isn't frail, if the patient's at an adequate plane of anesthesia or an appropriate plane, not adequate, appropriate, like not too deep, with physiologic reserve and the blood pressure drops a little bit, there'll be a slight increase in heart rate, a slight vasoconstriction without us having to do anything as that organ tries to return to homeostasis. So the stressor was the hypotension from the inhalant, and the physiologic reserve kicked in and brought the blood pressure up a little bit. So sometimes we don't have to respond at all. I mean, always we should consider turning down the gas, make sure that they're at an appropriate level of anesthesia. But again, that might fix the blood pressure. In a patient that has frailty, they don't have that physiologic reserve. So if the blood pressure drops, that physiologic response doesn't occur. And so that's what puts them at a higher ASA risk. Not, again, I know I've said it 1,000 times now, the age itself.
And I think we need to keep repeating it to say it's not the age itself. It has to do with these comorbidities. And until I read your article and we started having these conversations, I think there was a part of me that said, yes, I feel comfortable anesthetizing older animals, but I know that there's other factors I have to take into account. I know the blood pressure I'm going to tolerate in a 2-year-old dog in for a spay is different from what I'm willing to tolerate in a 13-year-old cat. Is it either has CKD or is at risk for CKD? But I didn't have a word to explain that. And frailty makes so much sense. And I think when you say frailty, there's this piece that sort of, you're like, oh, okay, yeah, that frailty, but what does that actually mean? And so to define it as this lack of physiologic reserve, I think just brings that whole, I hope this makes sense, brings that whole thought process full circle of like, this is an older patient with comorbidities. I have different things I need to take into account. Oh, and that is because they have less physiologic reserve because of this frailty that we're talking about. And there's a word for that to explain why we're approaching these patients differently. You mentioned blood pressure. What are some other examples where an animal might not have the same physiologic reserve as a younger, more healthy, well, I don't know, is more healthy the word to say it, less frail patient that we might want to pay a little closer attention to when we have these more frail animals under anesthesia.
Absolutely. And I want to go back right quick to the word frailty too, because I agree with you. That really puts it in a nutshell and makes us go, oh, okay, they're frail. They're not just old, but they have these changes that make them frail. And frail is also a word that pet parents understand, right? They know
Sure.
that means that you don't have the same robustness. They might not know physiologic reserve, but it's not the same robustness. And I think it helps because when I look at, I've got two grandmas and one is frail and one is not. And so when I hear frail, I understand this person that it has these same kind of changes. Now, again, I might not equate it to anesthesia, but I understand what it means. But now we are, for the audience, equating it to anesthesia. We're making frail science so that we can then respond with our anesthetic protocols using our science. And really, any organ system can be impacted, and often they all are. So, cardiovascular is a big one, and the blood pressure not responding. Also, respiratory, if we have respiratory age-related changes, the patient will become less sensitive to CO2. So, when the carbon dioxide goes up, that doesn't necessarily drive increased ventilation. So, they're more likely to get hypercarbic, hypoxemic, body temperature, more likely to get cold because the changes, again, like vasoconstriction is one of those, the changes that would increase the body temperature or maintain the body temperature aren't as effective. So we need to breathe for them, support blood pressure, be really proactive about keeping them warm. And then, of course, with age, there may be hepatic or renal changes too. So which drugs do we use? What's the fluid rate? So really any organ system can be impacted, and sometimes obviously multiple and maybe even all of them. But that doesn't mean we're not anesthetizing them. That means we need a trained anesthetist that's watching that patient and making the changes for the patient that the physiologic reserve would normally make. So fixing that blood pressure, breathing for the patient, and really supporting that patient.
Gosh, I love the science of it. It makes so much sense because without having that word and that understanding of the concept, like I said, I feel pretty comfortable anesthetizing older animals, but I won't lie and say there isn't a little bit of like an adrenal squeeze that happens or I'm like, oh gosh, please be okay. And it's almost like there's this internal conflict when you're preparing for those kinds of things. You're saying, like, let me do added heat support and make sure I have enough hands so that I can ventilate if I need to, and what drugs I have available. But then, we're always told like age is not a disease. And so you're like, but I'm doing all these things and I know I need to do all these things, but age is not a disease. And it's like this mental, I don't know, like this cognitive dissonance that happens. So when we can say, yes, age is not a disease, but frailty is a factor that plays in and we need to keep that in mind, then I don't know, I think it takes away that internal conflict in my brain as I'm preparing to support all these body systems in a little bit different way than I would in an otherwise young, healthy patient.
I love that. I love it's causing you to rethink it because you're right. Age is not a disease. Senior at 7 doesn't mean anything, but these age-related changes do. But what that makes the patient has nothing to do with age. It's just a higher risk patient that we should treat as a higher risk patient, whether it's 2 years old or 20 years old. Our brain would be saying, like you just said, we need to breathe for it. It needs more heat support, maybe more pain management. But it's not because it's age, it's just because it's a higher risk. The age maybe made it at higher risk, but you're right. We can eliminate the age is not a disease fear in our brain and just say frailty.
So how do we assess frailty in our patients? I mean, I feel like without having the words, the vocabulary to describe it, like just having the word is helpful. But I mean, are there ways to kind of objectively evaluate our patients for frailty, or is it more of like a gut check?
Absolutely, we should be evaluating them. And for anesthesia, it's really just our routine anesthesia, good physical exam with extended exams for any abnormalities we find. So if we hear a murmur, we might want to do an ultrasound or radiographs. Or if we hear what sounds like or if we feel a pulse and there's some skips, we're going to do an ECG. We want to do all the blood work, all the laboratory analysis that patient needs. And if we see an abnormality in BUN and creatinine, we do a urine analysis or whatever. I mean, that's standard physical exam, lab work that we do, further diagnostics in any patient, whether it's 2 or again 20, those are the things we would do as we found abnormalities. We would do further diagnostics. So treat it just like any high risk patient or riskier patient, not necessarily high. But if you really want to get into gerontology, there's also frailty scales in veterinary medicine, like there are in human medicine, where we can really work with the client. So this is a bigger picture than anesthesia in describing all the lifestyle changes that that patient might need. So remembering to talk about the sticky mats for the floor, the non-slip mats, and maybe changes in nutrition, and maybe changes in just how we are around that animal. Maybe its vision is decreased, and so it's startled easily, or maybe it can't hear. So when we're screaming at it and it doesn't come, it's not a bad dog, can't hear us anymore. And those frailty scales, I think, are really useful. And they are just a series of questions that you are probably asking anyway, and that we would be asked as we age. And things like I just described, mobility, can your dog or cat still go up and down the stairs? Does your dog need help rising? Does your dog have any GI changes? It's vomiting more or whatever. So these are a lot of questions that are already probably in your record if this is a patient that's been your patient for a long time, and or that you may be asking as part of the exam. So when people look at the list of questions, that one of the frailty scores has like 33 questions or something, it's like, oh my gosh, I can't ask all of those. But you know most of them already, or you're asking most of them already. So it's just kind of putting those together in a picture that is holistic for that patient. It's not just anesthesia, but also, and not just acute pain management, but also chronic pain management. And as I mentioned, things that how we can support cognitive decline and nutrition. So yeah, there's some good scales coming out in veterinary medicine, and I hope people start embracing these. And I'm gonna put a shout out for the technicians here for anesthesia. I mean, we should talk about that too, but also for maybe that's the person who implements the frailty scales in your practice, because they're often asking the questions anyway. Is your dog vomiting? Is it, whatever, in the quick check in the exam room before the veterinarian ever comes in? So they can really get that information and help implement this in a clinic.
Oh, 100% have to shout out to the technicians. I mean, having someone who you feel confident, like they've got it, and they're going to let you know if there's a problem, and they know what to look for, and they know how to manage this patient. And then being able to focus on a dental procedure or surgery, whatever it may be, is, oh my gosh, it is just invaluable. I mean, a shout out isn't, I don't even know what to say about all of you out there. Like, it just couldn't do it without you.
Right, absolutely. And you're right. A shout out's not enough. It's like praise and
Yes, like thank you,
yeah,
thank you for
yeah.
saving us and allowing us, to do the things that we do, because certainly, gosh, it's so necessary. When we're talking about these frailty scores, it sounds like there are a lot of lifestyle questions. I don't know if that's the right word for it, but like you said, GI issues. Can they get up? Can they see? Can they hear? These kinds of things. Are there frailty scores that take into account things like our diagnostic testing? So heart murmurs, arrhythmias, endocrine disease, and things like that as well?
Absolutely. And it's part of some of the bigger scales. And so, like I said, that stuff you're doing anyway. And then if it's not really your thing to do a whole frailty score, taking into account all the things that we just said is, and I know I mentioned this, but just to bring it home again, that really is what you would do, the lab work, the physical exam, to give the ASA score. And again, even if you don't exactly score it, remember the ASA, the American Society of Anesthesiologists scale. So 1 is a perfectly healthy patient, where anesthesia is not an added risk. As the patient has more comorbidities, anesthesia becomes riskier. And then, the ASA 5 is where we wouldn't anesthetize an ASA 5. They are dying unless anesthesia would potentially allow us to do a procedure that might save their life. Like there's a ruptured hemangiosarcoma or something that we have to go get before they bleed to death. So kind of putting it in a scale like that, even if you don't do the true frailty scale, that's what we should be doing for every one of our patients, is in our head telling ourselves what is the risk level. And it works. If we all are on the same team and we know, okay, this is a medium risk patient or a high risk patient, it does change our focus on that patient. It shouldn't. I mean, we should focus on every patient, but it does make us a little more quick to react, a little more hypervigilant, a little more splenic contraction in ourselves, the anesthetist. And that's how it should be. We really should be focused on that patient, whether we use the scale or not, but using all of our diagnostics to decide really how hyper vigilant we should be. We should always be vigilant, but there's sometimes hypervigilance is required.
Yes, yes, I love that. That puts it into perspective to say, we need to be aware anything can happen at any time. But, I love that you put the science behind it to say there are patients that we do need to be a little bit more hypervigilant with. And it's not because of their age, it's because they don't have that physiologic reserve to respond themselves. So we're going to have to jump in and respond for them a little bit sooner. And so watching out for them more closely and yeah, and it kind of eliminates that internal conflict of like, is this just because they're older? No, it's because they have this higher frailty score.
Right, and I do hope that changes everybody's thinking because you're right, which is I know it's an old patient. And if you are new to anesthesia or maybe you haven't anesthetized a lot of patients yet, that really might completely blow your mind. Well, he's old, so I don't know what to do. Yes, you do. You would do the same thing with any patient. We just have to support what isn't supporting itself because that physiologic reserve isn't there. So you do know it's not about age.
Yes. Oh, yeah, exactly. You would respond, the same way, just, a little bit quicker, maybe a little bit more aggressively.
Yeah.
And when we're thinking about that of like, oh, they're old, now I don't know what to do. If we kind of change that thinking like, okay, they're frail, now I don't know what to do. Are there certain medications, or I guess medications would be the biggest thing that we should or shouldn't keep in mind in these patients? Like, are there drugs that are more safe or less safe or we should avoid, or techniques that we might not be thinking of to help make anesthesia safer for these patients?
Sure. I think for the drugs themselves, it would be more about what did our diagnostics discover than the age. So, for instance, if there was hepatic insufficiency, so we see that on the blood work, I wouldn't choose a drug that is strictly hepatically metabolized, like acepromazine. So, if there's whatever the age, if the liver is not really clearing drugs, then I don't want to use a drug that wouldn't be cleared and might last a really long time and it's not reversible. So the underlying change or comorbidity might change the drugs that I use. But the what would change really more likely is not necessarily the drugs, but the dose if there's frailty. Because one thing that happens with age is several things. And one of them would be we mentioned liver, so the drugs may not be cleared as quickly, or if they're renally eliminated and there's kidney changes, they wouldn't be cleared. And then also, as our brain ages, there are fewer sites for the drugs to bind to, fewer receptors. So the dose needs to be lower in those patients. And also, we need to administer, if we're giving IV drugs, administer the drug slower because if the circulation is impacted and the circulation is not as robust, it takes longer for that drug to get to the brain. And so we call it low and slow. So for instance, as you're titrating propofol, start with a lower dose, maybe 3/4 of the dose you would have given a dog without or a cat without frailty. And so give that low dose. And then instead of waiting 30 seconds to a minute, wait a minute or two, which I know is excruciatingly a long time in anesthesia, but let it get to the brain before you give more. And then do not eliminate pre-meds. We need those pre-meds to build on. And sometimes the pre-med might just be an opioid because the opioid would then give us the analgesia and a little bit of sedation. And maybe that's all they need. So we want to start with that pre-med because that really does decrease our induction dose and our inhalant dose. I call it, I say it's building a cake. And the pre-meds that's the cake. The pre-meds are the cake. And then the induction drug, it's just a little bit of induction drug. So it's the frosting. And then the inhalant should just be keeping them at that anesthesia level on top of all the cake and the frosting. So that's the sprinkles. The inhalant should just be really low dose. So building that cake, don't eliminate the cake part. We need that pre-med, but it doesn't mean again that we need ACE or that we need a big dose of dexmedetomidine. But I want to come back to that for just 1 second. Because age is not a disease, the senior at 7 does not eliminate alpha-2 agonists. I don't know who came up with that, but I'm just going to pick two 10-year-old Labradors. And one Labrador, it acts like it's two. It plays ball. There's absolutely just no age happening in this dog. I'm not going to anesthetize that dog without maybe some alpha 2 agonists unless there's other reasons not to. Whereas maybe the same 10-year-old Labrador that is very frail, we don't need that potent of a sedative potentially. I might still use it because it's reversible, but I might not eat it. Maybe the opioid's enough again. So that maybe not eliminating drugs because of age, but because of the underlying changes, but really thinking about those changes and which drugs we might want to leave out.
Well, the dosages thing, I mean, that's another one of those that I love that like we're putting science to this because I'm like, I think this is something that we do, but I don't know that I have really known why before I was today years old when I learned this. And that, it's like you see it in your patients that they respond to lower doses and yes, like giving it more slowly, but that makes sense that there's fewer receptors, so it's easier to saturate those receptors. And then, yeah, if I hate to use this example, but we see it with euthanasia when we're talking about how we give it. If you give it quickly, it feels like you're waiting an eternity for it to take effect, and things can happen along the way that you're not expecting. But that low and slow, especially because, God willing, these are hopefully older animals that, and more frail patients that we're euthanizing. That low and slow, like you do see that much smoother curve of effect that you're looking for to make this a really peaceful situation. Like I said, I hate to use euthanasia as an example, but I know coming from large animal where, you're administering just as fast as you possibly can versus like small animal, that's one area where I know there's a huge difference in rate of administration of medications. Gosh, I feel bad that I used euthanasia as an example.
We go back to anesthesia,
I
euthanasia.
know.
No, it's a really good example because we're changing the CNS with both of these instances. And actually it turns out kind of good because I know some people are so afraid of anesthesia because they're afraid of death. Well, anesthesia, yeah, if we do it badly, could cause death. But we in this podcast are discussing how we're not going to do it badly. So we can distance that similarity between between the two.
Yes, yeah, like yes. Take it to heart. This is not about death and euthanasia. Just one area. I think of like those patients with heart disease and stuff like that, and just some of the differences we see. But yeah, to say like go slow with your medications, and that there is science behind it to say if there are fewer receptors, you don't want to just oversaturate those receptors and have this really prolonged effect. And you don't want to give your medication, have it on board, all of a sudden that circulation hits the brain and it just hits like a truck instead of this nice slow induction of the medication that you're looking for.
And that it gives the physiologic systems time to adapt a little bit as things are changing. And in a patient without frailty, that happens really quickly. And plus, the cardiac output is usually good, so the drug gets to the brain very quickly. But these patients just need our extra care because low and slow really is what they need. So not drugs necessarily, except unless there's underlying disease, but definitely rate of administration and dose.
Can we dive into the alpha 2s just a little bit more? Because I have such a love-hate relationship with dexmedetomidine, and it's become much more love as I've used it more and more and gotten more comfortable. And, I remember talking to Dr. Reed, Matt Reed, and I was like, yeah. And then all of a sudden I'm getting like ventricular escape beats. And he's like, that just means you were doing a good job. And I'm like, you are not worried about this at all, are you? And he's like, nah, it's a safe drug. You can just reverse it. And, getting that kind of feedback has helped with my comfort level to say, there are like you said, people are worried about death, but there's so much that we can do to intervene and prevent that if we're prepared. And so getting comfortable with, that bradycardia and things like that, and knowing this is a reversible drug. So in some ways, it's kind of nice to have an alpha 2 over, say ketamine or something, which I love ketamine, in my patients. I think it does a great job, but it's not reversible. Once it's on board, it's there. And so yeah, I'm wondering with the alpha 2s, are there specific changes you make, or is it primarily just in dosages or like situations where you're like absolutely not an alpha 2? How do you look at those in these more frail patients?
And it's one of my favorite drug classes, so I'm so glad you asked alpha 2s. And for a couple of reasons, and one is the reversibility. You're absolutely right. That is a safety net that we don't take into account. We know we can reverse them, but we don't think of it as a safety net. That should make us more comfortable using the drugs. We can take it back. I like that there's also some analgesia, excuse me, along with the sedation, which we need to talk more about pain relief too. I forgot you asked me earlier and I forgot. So we get some analgesia, and it's what I call titratable. You can give the low end of the range dose and just get a calmer patient, like we might want for pre-meds, or you can give the high end of the range and get a really sedate patient that we can do painful radiograph. Well, the radiographs aren't painful. Radiographs in a painful patient without it reacting, and then you can still reverse it. So for me, age is absolutely not a reason to eliminate the alpha 2s. Only cardiac disease would be a thing, a reason I would not use an alpha 2. And remember, a murmur is not necessarily a disease, especially in aged patients. They may have a heart murmur, but no signs of disease, no decreased, no exercise intolerance, no cough. So heart disease itself, yeah, I probably wouldn't choose it. The thing is, if the heart disease is extensive enough that I would be afraid of an alpha 2 or concerned, usually they don't need an alpha 2, right? They don't need that potent of a sedative anyway. So it doesn't come up as a decision very often. But really, I'm with Dr. Reed, safe drug class, with the exceptions of the ones we wouldn't use it in, and that's true of every single drug. And then the bradycardia, I'm just going to say to everyone, especially the technicians who are having to do the monitoring, the bradycardia, we should just stop fretting. It's normal and it's brilliant, actually. It's the body being smarter than we are. It is a physiologic response to decreased cardiac work. So what happens with the alpha 2, since they cause the vasoconstriction, and that's why we wouldn't use it in advanced heart disease, because that heart can't eject blood in those little vessels, or it has a harder time. So the vasoconstriction makes the blood pressure go up, and the carotid bodies sitting right here go, whoa, the blood pressure is good. And it's not heart rate that delivers oxygen to the tissues, it's blood pressure. It's really cardiac output, but we don't measure that. So we're going blood pressure. So the carotid bodies go, whoa, pressure's good. Heart, here, I'm going to send a signal down the vagus nerve to slow you down. You don't need to work so hard. The pressure's fine. It's brilliant. So we should embrace the bradycardia and not fret about it.
Now that I've developed like more of a love relationship and less of the hate relationship, I'm with you. Like I love an alpha 2 for sedation, and I've gotten much more comfortable. And I think of, I forget who said it to me, but they were like, there's only so many heartbeats in their lifetime. So if you slow it down, then you're prolonging their life because that's fewer heartbeats. I was like, sure, I don't know if that's true, but it makes me feel better.
I thought of it that way, but I like it too. Yeah, that's it's a good comfort statement.
Yeah, yeah.
Well, then back to the age, we have a lot of hunting type dogs around here. And so there's a number of German short hair pointers, and I don't care how old that breed is. I can't deal with them without an alpha 2.
No.
I don't, but it's about their personality and their vigor and their energy. And so the age really has to be like, no, because wrestling patients is worse than an alpha 2. Again, unless the alpha 2 there's cardiac disease, and we probably aren't wrestling those. But wrestling, that's a huge physiologic stress for that patient. Just think, just you utilize all of your catecholamines in that stress response. And then there are a lot of times when we anesthetize those patients, the blood pressure is low, they don't want to breathe because they just dumped all their catecholamines. So not only is it bad for them, but it's really bad for us and our staff and anybody in the lobby that can hear the struggle. Like, we just should not wrestle with patients. That's not the right way to manage them. And there's a great behavior study. There's a lot of great behavior studies out, but the one I'm quoting, I don't remember the author at the moment, but it was about when dogs would be reactive in a clinic. It was dependent on their previous visit. There was really not as much breed or gender input that we think or that we say is we believe. It really was about the previous visit. So if we can make every visit awesome, that makes it better for the patient their whole time that they are with us. So wrestling has a lot of negative consequences. The alpha 2s are a really good drug to fix that. And again, if we had to sedate for just an exam, we can reverse it and they can go home. So that reversibility, Dr. Reed is so right. It's amazing.
Yes, yes. Now we can get in like pre-visit pharmaceuticals and all these things. And gosh, if we had like I don't know, I would sit here all day and talk anesthesia and all the different nuances to it. In the interest of being respectful of your time and of listeners' time and things like that, I want to spend a little bit of time talking about technicians. You mentioned, because a lot of times it is a veterinary technician who's doing the anesthesia monitoring and having to watch this bradycardia and ventricular escape beat or AV block or whatever it may be, if it's an alpha 2, or some of these other indications of uh, lack of physiologic reserve that we need to respond to. So I guess I'm just interested in like your overall take in the role, the importance of veterinary technicians in anesthesia.
Oh, huge. And I'm so glad this is another favorite topic. And I want to back up just 1 second to the pre-visit pharmaceuticals. Don't leave those out in these seniors with frailty, especially if they have a cognitive decline or different phobias. We want to make sure they come in calm, keep them calm the whole time. So we want to start with those, even in these patients as well. I see those being left out because they're old. They actually probably need them more than some of the younger patients because they very often have anxiety. Again, maybe they don't hear as well, they don't see as well. That can add to that. And then pain management, pain management, pain management, and trying to control chronic pain before we cause acute pain, because acute on chronic really amplifies that pain. And also using non-sedating drugs like do your local blocks, do as many local blocks as you can. That the local block drug class is my absolute favorite. I wish I'd invented it and I would sell a lot of it, make a lot of money, but I didn't invent it. But we get this very profound analgesia that's non-sedating. So don't forget your local blocks. Okay, so back to the technicians. Yes. And what I see in a lot of clinics is not fair to the technicians. And it's because maybe us doctors we know about anesthesia, so we assume the techs know or they can handle it. But gosh, remember, even as doctors we're sometimes nervous, but remember learning it as a student, not knowing this is one step closer to death than just real sleep. It's really deep. So training our technicians is huge. Give them the tools, give them the knowledge to be the anesthetist if we're asking them to be the anesthetist. And I'm not saying every clinic needs a veterinary technician specialist in anesthesia and pain management, although that would be awesome.
That would be amazing.
Wouldn't that be amazing? Every practice should have one, but in case you don't, take the time to train who you do have doing that anesthesia. And another thing I see a lot is sometimes the newest technician is, and not always, I'm using the word technician, assuming that that's who's doing the anesthesia, but sometimes it's an assistant. Seeing the newest person put on monitoring anesthesia because they just write down the numbers. And in healthy patients, we often get away with that. But if there's a change, that person doesn't know what the change means. They're just writing down a number. So in these frail patients that are very likely to have changes under anesthesia that require us to fix it, immediate input from that anesthetist, that's not the person to be doing anesthesia. Our patients under anesthesia are very forgiving if they are healthy, not frail, not diseased, because they can take being too deep and still do fine. But the patients we're talking about won't be that way. And plus, it shouldn't be. They're fine. We need to train. So really giving those technicians the knowledge, send them to CE where anesthetists are speaking. There's a lot of classes online. Let's get them trained so they're comfortable and so that they know what those numbers mean and they can make the changes. They know if the blood pressure is dropping. They don't have to ask the doctor, you're knee deep in your surgery, you're elbow deep in your surgery, I hope. So they know to turn down the vaporizer and they know they need to breathe for the patient and maybe not take over, but breathe a couple of times a minute to keep that CO2 a normal level or give them a little bolus of fluids. They know what to do and they're more comfortable, but they also know when to be hypervigilant. And so that I can't say enough about training the technicians. They've got this. They can be the anesthetist.
100%.
Isn't it true? I mean, they can do this, but we shouldn't just throw them to it with no training. It's amazing to me that how many practices I've seen that do that. And I bet it's nobody listening to this podcast because everybody podcast is interested in anesthesia, obviously, or at least interested in senior patients or both. So probably nobody listening here. But if you know of anyone that's doing that, help them train their technicians.
Or, maybe it is somebody listening who has been kind of thrown to the wolves with anesthesia and they're saying, let me figure this out a little bit more. Gosh, I couldn't agree more. Like the collaboration that can occur when you have a well-trained anesthetist. I'm thinking of a few people I've worked with where again, I've been able to focus on whatever the surgery is that I'm doing. And they've been able to say, hey, this is what's going on. This is what I want to do. And sometimes maybe it's a technique that I really haven't used very often, whether we're talking about, different CRIs or local block techniques and things like this. And just like I said, I just recently made the jump into emergency. Now we're talking like, drugs like vasopressin and norepinephrine, which, those we don't have in general practice for the most part. And so when you have somebody who is well trained, who understands more than just I need to write down the number and there's these two things that I can do to potentially adjust it because it shouldn't be outside of this range. When they really understand how the physiological mechanisms work together and what the interventions we can take to correct them, I can think of multiple situations where they're teaching me, not the other way around. They're saying, this is what I want to do. And I'm going, what is that? And, they're going, yep, I've got you. Don't worry. And it ends up really working out so well for the patient when we're able to bring multiple different knowledge bases together to come up with a solution and get this procedure done.
Absolutely. And good for you for listening to them as they're saying, this is what I'd like to do. And especially the ones we've trained or that we've sent them to CE come back with new ideas. Let them try new local blocks. Our technicians are always coming back with a new local block. Like, wow, I didn't think of that one. And you're right, the CRIs, so many technicians come to me and say, I want to start CRIs in my practice. How do I do that? How do I convince the doctor? So I love speaking with a doctor like you, where you're listening to that technician. Please listen. Everyone out there, please listen to your technicians. And like you said, under anesthesia, that really helps when the person is trained and can just say, pressure's a little low, I'm turning down the vaporizer, or can I give another fluid bolus? Are you okay with that? And then you can focus, and that's better too because the procedure goes faster and
Mm-hmm.
you're less likely to make mistakes as the surgeon. You're not going to nick a big blood vessel. It's going to make everything worse. So that communication and trust is really, really huge and so much better for the patient that it's just unstateable how much better that is.
And again, being sensitive to time here because I know we're getting close. Again, I do just sit here all day and have this conversation because I love being able to pick your brain on this topic. But I guess kind of to wrap up here, when we're thinking of some of these newer technicians that you're describing that maybe they've been trained, but they still don't feel very experienced, or maybe they are one of these that just got they feel like they got thrown into it. What are some of the more go-to changes that they can think of to help address changes under anesthesia, low blood pressure or bradycardia, tachycardia, things like this, to help keep these patients stable and address any concerns quickly in patients who do have less physiologic reserve? Did that question make sense? I feel like it was very wordy.
Oh, it's great because you're creating the picture for all of us. And for one thing, I'm going to come back to technicians just a second, but also for the doctors, and maybe the train techs too, and maybe train to everybody. It's not about us, right? It's about the patient. So don't have any ego. If as the doctor, if a technician says, I don't know if this drug is right, or did you really mean this dose or whatever, take the time to think about it. And if it is right, answer, thanks for checking, but I chose it for this reason. That's part of education. Or if you're the trainee, don't think that you know. You don't know. This is anesthesia is really life and death, though. You don't know. So no ego. And then some go-to things, first of all, is be really robust with your pain management. And that's it. Again, if you feel like maybe that animal needs some more pain relief, ask the doctor, would a local block here help? I'm having a hard time keeping the vaporizer at a setting that maintains the normal blood pressure. Or can I give another bolus of opioids or something? Really, that pain management should be, that's part of the cake. And that is, it allows us to keep the inhalants low because the biggest go-to is keep your inhalant as low as you can, because that is the biggest contributor in most patients to hypotension, hypoventilation, long recoveries, hypothermia, right? We have to keep that vaporizer
Dysphoria.
high. It affects everything. So keeping that vaporizer low, and even if that means little boluses of propofol instead of just, or alfoxylone, instead of just relying on that vaporizer, that's really kind of go to analgesia, keep the vaporizer low. And then if there's changes physiologically, say them out loud. The heart rate just drops. So everybody knows, the doctor hears you, even though you're focusing on your surgery, everybody knows there's a change. And okay, is it an anticholinergic? Is it what do we need to do to fix that? Do we just give an alpha 2? So saying things out loud and being a team is really a go-to as well. So I don't really have any go-to exact drugs, but go-to situations.
Sure, just good communication and making sure that we have a reasonable grasp on that physiology so that we can address these changes, which, like you said, a lot of times come down to keeping that vaporizer low and making sure we have good pain management. Then I don't know, I feel like they're more forgiving than I expect them to be in a lot of scenarios. Not every time, but in a lot of scenarios.
I totally agree they are. And when they're not, if the frailty changes mean that the blood pressure is not going to come up, and we already know that before we start, we've got our dopamine ready or dobutamine
Hmm.
ready or ephedrine ready, whatever you're using to improve that blood pressure. And a lot of practices maybe don't have those tools because maybe you're not anesthetizing a lot of patients that need them. In emergency, you would have those tools for sure. And practices that don't, maybe it's something to add to your formulary. I'm not, excuse me, trying to add everything to your pharmacy is what I meant, but maybe that's something to add. So when those patients with frailty, we know that turning down the vaporizer is probably not going to be enough. We still start with that, but we want to have our blood pressure products available. Turning down the vaporizer may not be enough to return them to normal ventilation. So again, we may need to support ventilation. We very rarely have to take over, but we may have to breathe intermittently to keep that CO2 normal. And just being ready to respond, knowing that this patient's physiologic reserve may not give us the response that it would if it was a patient that doesn't have frailty. So be ready.
And like bringing it, I think you just brought it back around full circle that when we're looking at these patients, say in general practice, and wondering, is this safe for me to anesthetize, or is this something that maybe I should consider referring? Sometimes when we're thinking about it through the lens of age, there is this internal conflict of like, but age is not a disease. But if we can look at it from a frailty standpoint, and like you said, we know this is a patient who is very likely to be hypotensive under anesthesia, and we don't have the pressors and things to help control blood pressure, well, that might be the time to have that conversation about, is this the right situation to anesthetize this patient? Or you say, I love anesthesia and want to be more involved in anesthetizing these patients and handling these cases. And yeah, then maybe having these drugs and things on your shelf makes sense in your practice. But looking at it through the lens of frailty, I think just helps those decisions feel much more clear as opposed to, like you said, thinking about age, which really is just a number.
It really is. It's the number of birthdays. And I love that you brought that to referral because I think a lot of veterinarians don't think about referral for anesthesia because they can do the dentistry or the procedure, the lipoma removal or whatever. And absolutely, of course you can. But referring for anesthesia, people don't think about that. And yes, and it doesn't have to be academia. If you live far from a veterinary school or something, there's a lot of us in private practice now, a lot of board certified anesthetists, and there's mobile anesthetists, and there are anesthetists online that can log into, if you have the right software, can log into your software at your clinic and help you monitor or at least answer the phone. So there's a lot of ways to get help and not say this dog or cat, I keep saying dog or cat is too old for anesthesia, so we're going to do nothing. That's not right for the patient. They need us. They need anesthesia. So I love that you brought up referral.
I'm just amazed that you were able to bring it full circle so effortlessly like that. And Dr. Grubb, once again, it's been so much fun talking to you, and I'm so glad that you agreed to come back on the podcast. And I would sit here for another 2 hours and have this conversation because I'm just picking up. I feel like we've just scratched the surface here, and there's so much to unpack. And once again, walking away having learned so much. So thank you for coming on the podcast. Is there anything we missed? Anything you want to make sure and leave listeners with?
I can't think of anything. If there are questions, hopefully they can let us know, but I can't think of anything. And I appreciate you right back because every time we have a conversation, we cover so many things and things that I wouldn't have thought if I was just giving a lecture. So I hope that it's a really rich body of information for the listeners because of all the things, the questions that you ask and bring out these crazy answers that I ramble on about, but hopefully it's helpful to everyone. So thank you for having me back. I love it.
Oh, absolutely. Definitely helpful to me. So if I'm any example, then tons of good information here. Dr. Grubb, thank you again for joining me. It's always such a pleasure to get to talk to you. I learned so much. So, many, many thanks for coming on the podcast. I hope we can continue this conversation because there's so much more to say. Thank you to everybody who tuned in and listened to this episode. If you enjoyed it, be sure to check out Dr. Grubb's article in today's veterinary practice called "Can a Veterinary Patient Be Too Old for Anesthesia?" And we would love it if you would leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and other great content we try to put out there. For more episodes, you can click on the education tab on the VetFolio website or find us wherever you get your podcasts. Of course, I want to hear your thoughts on this episode. I want to hear ideas for topics you'd like to hear from us in the future. So feel free to reach out to me at dvm@vetfolio.com. We can also connect on Facebook at Dr. Cassie DVM, or you can find me on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.